So we knew that hyperbaric medicine or hyperbaric oxygen therapy induces new blood vessels in those diabetic wounds. I'm going to share a very slide here that's kind of critical to understand. This is a nice slide from the Weizmann Institute in Israel that was recently published. And what it shows on the left side is how a wound in our leg or in our hand is healing. And on the right side is a wound in our brain, which is a stroke. And when I grew up, when I got my medical education, people have told me you cannot repair the brain. Nothing
Mm.
can. But we know today that it's not true. We can repair the brain.
This is the Recovery After Stroke podcast with Bill Gasiamis, helping you navigate recovery after stroke.
Hello and welcome to episode 250 of the Recovery After Stroke podcast. On this episode of the show, we are joined by Dr. Amir Hadani, a Harvard Research Fellow in the Brain Modulation Lab, to discuss hyperbaric oxygen therapy as an intervention for stroke recovery. Dr. Hadani has a background in neurosurgery and bioinformatics, with a particular interest in using machine learning to improve neuromodulation therapies. He has been leading the analysis of an olfactory network mapping project and will share his insights on how hyperbaric oxygen therapy can benefit stroke patients. We'll discuss the science behind hyperbaric oxygen therapy and its potential to improve brain function and promote recovery after stroke. Dr. Amir Hadani, welcome to the podcast.
Thanks for having me.
My pleasure. Thank you for being here. Now, the work that you do interests me a lot because I'm a stroke survivor and the podcast is called Recovery After Stroke Podcast, and lots of stroke survivors do listen and they're looking for ways to support their recovery and to heal their brain after a stroke. And one of the things that does come up from time to time, and there doesn't seem to be a lot of information about it, is the kind of work that you do, which is in the space of oxygen therapy in the hyperbaric setting. And we hear about hyperbaric therapy, and we hear about how a whole bunch of people can get a tank and put it in their house these days. It's really developed a little further, but there's still not enough information out there to inform the general stroke survivor, the general public, about how beneficial it is, if at all. Now, I know you're doing some interesting work in that space. Before we talk about that work, can you give me a bit of a background on you, how you came to be involved in oxygen therapy? Give us a little bit of insight.
All right, perfect. So a little bit about myself. So I trained as a neurosurgeon, then continued to do functional neurosurgery. And I also trained as a hyperbaric physician. I have a PhD in bioinformatics and data science, which really makes me a big data nerd. So I'm really all about data. That's how I practice. I have to have data in order to get actual clinical decisions. And the story behind, and I guess most of the listeners would ask, what does a functional neurosurgeon doing with hyperbaric medicine? And it all came down back in 2008. One of my MD instructors, Professor Shai Frati, who started managing a hyperbaric chamber. And I was doing my residency in neurosurgery, and he was treating diabetic patients for non-healing wounds. So wounds in the legs for diabetic patients. That's a common indication for hyperbaric oxygen therapy.
Mm.
And some of them had previous strokes, and all of a sudden they reported, my speech is getting better, my hand is getting better, my leg is getting better.
Mm-hmm.
So he calls me up after 3 patients, and I tell him, I don't know, I'm probably the most skeptical guy on the talk here. And probably in the world. I told him, no way, I don't know about this. So after he collected several more patients, we decided we need to do a study. We need to do a randomized control study to actually see if there's anything in this. So we started then. I was excited because I was in my residency. I had patients who suffered from stroke that we treated. We gave them TPA or did a thrombectomy, which is the endovascular intervention to try and salvage as much of brain tissue as we can. But eventually, as you and your listeners know, there is some disabilities that you remain regardless of the treatment you're getting. So I was excited that we may offer something else for our survivors. So we got and did the randomized controlled trials, and the results were astonishing. The first study we did was on motor function, neurological function, and quality of life. And what we have shown that all the patients that we selected for this study, and I'll touch on patient selection a little bit later, got significant improvements in their neurological function and in their quality of life. And we compared it to a control group that did not receive that. And after the study was done, we crossed them over, meaning that the control group now received the treatment and got our protocol, and they improved just as much as the treated group. So that kind of nailed it down.
That makes me smile because very often you hear in studies, the control group doesn't get the benefit of the other people in the study, and they usually miss out, and it's a bit of a shame. I love the fact that they got to experience the same protocol. So before we talk about the protocol and the different things that you discovered, is there a difference between a functional neurosurgeon and a standard neurosurgeon?
Yes. Yeah. So just to touch back on the previous point, yeah, I have to touch on that both me and Professor Fadi are really finding it hard on the ethical part, that leaving the control group or the placebo group untreated. So we always try to stick it in our Helsinki's or IRB reviews that we want to treat the control group if it works. So that's what we usually do.
I love it.
Now, the difference between a neurosurgeon and a functional neurosurgeon. So standard neurosurgeon treats trauma and stroke and brain tumors. A functional neurosurgeon specializes after he completes that, he specializes in functional disorders such as movement disorders, Parkinson's or essential tremor or epilepsy or pain, and try to improve the quality of life with different procedures or implementations of devices.
Okay. Now, at the beginning, you also mentioned you're a data nerd. So that meant that when you had people going into the hyperbaric oxygen chamber for diabetes, and 3 of them reported back that their neurological symptoms improved, for you, that's just, it's not real evidence. It's just anecdotal evidence.
Correct.
But it's the type of evidence that should make your ears prick up and go, well, this is interesting at least. And why are these 3 people reporting that? Is that how that process begins to start to evolve into a proper study? Is it that they came to you, or is it that you guys hear that information and notice it from a number of people and then say, can we create some kind of study around this? How does it get from anecdotal to actually becoming a proper researched thing?
Yeah, I think that's the natural history in science everywhere, right? It starts with a couple of case reports or that people collect data from different areas and then think, okay, this is worth studying or not. A lot of times it's by chance. So on our case, we had those 3 cases, and we looked in the literature to see if anyone else encounter this. We found several more case reports.
Mhm.
So we decided, yes, it's worth to check. And you know, making a study, conducting a study is really hard. It's a human study. A lot of people are doing, you know, you hear it in the paper. These guys found the cure for cancer. These guys found the cure for Alzheimer's. And then when you read in line, you see it's actually rat studies or mice studies or pigs or rabbits or you name the model. Doing an animal study is easy, okay, for two reasons. One, it's cheaper. It's easy to get the animals. It's easy to conduct it. When you're doing human studies, it's so complicated. It costs a lot of money and it's a lot of effort to get the patient, to treat them, follow up with them. So it's a big, big thing to do a study, and especially in hyperbaric medicine. I think hyperbaric medicine is one of the fields that you don't have any pharmaceutical company behind it. So there's no funding, there's no you know, patent involved in it. So nobody's going to give you the money to do it. Nobody's going to donate it. So it's really hard to do a study in hyperbaric medicine. So you have to have good anecdotes to persuade you, okay, this is worthwhile studying, that there is maybe something in it.
And who funds a study like that? How does, if it's the pharmaceutical companies are not behind it, how do you use a private funding? How does it get up?
So usually we go to the funds from different, the government and different scientific groups or private donations or the hospital funds. Usually it's the hospital investigations funds that help us to do it.
Okay.
Yeah.
Awesome. Let's get stuck into it. Tell me a little bit about this first journey into hyperbaric oxygen therapy for stroke survivors. Tell me a little bit about that.
Okay, I think that maybe we can start with what is hyperbaric oxygen. I don't know if you've covered it in previous podcasts.
Probably not. That's a good place to start.
Okay, so let's go back to the concept of what's going on. So we're talking about a metal cage or a box or a room that's built from pure metal, and people go inside of it, closing the door, and then we're compressing air in it. So because it's built with metal, the pressure inside of it goes higher and higher and higher. And then when we reach a certain level of pressure, the therapeutic level, each patient is given a mask and he or she breathes 100% oxygen. And then what it does, it basically increases the level of oxygen to a very high level that you cannot get with just a regular mask. So people may ask why I have oxygen in the hospital or from an oxygen tank when I'm diving, but when you do it under pressure, you're able to dissolve much more oxygen molecules in the blood and then in the tissues and eventually in your brain. And we're talking about 20 to 30 times more than what we have currently. So that's kind of how it starts, what's going on when you're being exposed to it. But the more critical part of it is what happens if you do it repeatedly. So if you're doing it over and over and over again on a daily basis, that's when the therapeutic processes actually occur. And we can drill down to that a bit later if you'd like.
Yeah. Now, is oxygen always good for you? I've heard that oxygen can be bad for the brain as well. Too much oxygen in certain scenarios can be bad for the brain. Is that right?
So obviously, if you have an acute event, let's say an acute stroke or an acute myocardial infarction, on the first day or the second day of the event, usually you don't want too much oxygen, because when the damage is happening, right on the moment the damage is happening, if you have too much oxygen, you can create some oxidants, right? You know about antioxidants, obviously, but too much oxygen can cause oxidants and increase the injury, actually. So you don't want to have high oxygen at the moment of the injury, but let's say several days afterwards, no problem. There isn't really an issue of too much oxygen. However, you need to know how to do it. Definitely, there are certain protocols that if you're gonna get out of them or breach them, they can be toxic. If you're getting to a very high level of oxygen, let's say 5 atmosphere or 4 atmospheres of pressure, and you're trying to give oxygen, you can cause oxygen toxicity. So definitely you need to do it by a professional protocol and know what are the limits of safe oxygen. If you're breaching them, you can hurt your lungs and hurt your brain. Lungs can deteriorate in pulmonary functions, and brain can actually cause seizures. So definitely there is something that's called too much oxygen. So one of them, if you're doing it right in the event itself, but two is if you're doing unsafe protocols. You have to know what protocols you're doing.
Is that a risk of people having an oxygen chamber in their home?
Yes, definitely. That's a big no-no on my behalf. I think doing oxygen therapy at home is unsafe for several reasons. One, yes, you can actually cause oxygen toxicity if the chamber can actually get to those levels. And obviously, if something goes wrong and you're alone, there's nobody that's going to save you. And unfortunately, there have been accidents in those kind of stacks or chambers. So, and even a spark can cause fire, and then we're not just dealing with a stroke survivor. So that's on one end, but the more problematic side of this is the efficacy. A lot of people go into those chambers or sacks and doing, okay, I'll do something. But you're not following any protocol that has been studied. They just, oxygen is good for you, let's go in. That's not how it's done. You can consider oxygen therapy just like any other drug. It's not like you will go into CVS right now and say, I'll take this drug every now and then, right? You need to be prescribed a certain protocol, and you need to do it at the right timing, at the right amount, right pressure, right? And if you're not doing this, nobody knows if it's effective or not. So it's kind of taking medicine to your own hands, which I really don't like. If you want to do it, if you want to do oxygen therapy, do it with a professional and do it in the right way with the right protocols that were investigated and proved in a randomized controlled trial. That's what being a data nerd is all about. You have to do based on data. You have to do medicine based on data.
Yeah, fair enough. I completely agree. And there is a proliferation of those home tanks, and they cost a lot of money. AUD, Australian dollars, they start probably at around $20,000 Australian, and then they've got to take up some space in your home, and then you've got to get in them, and you've got to go through that process. I imagine that they become similar to treadmills. Everyone buys a treadmill, they put it in their garage, and they start hanging the clothes on it so that the clothes can dry instead of run on it. I imagine it's something like that, but I'm hoping that it's starting to get looked at as a more serious medical intervention to help people that have a stroke. Is the field fairly new, or is it a field that has been around for a little while?
So hyperbaric oxygen therapy or hyperbaric medicine is already more than 70, 80 years old. And because it started from diving accidents.
Mhm.
The whole field started by treating divers who breached protocols of diving, and the only way to help them from their symptoms, it's called decompression sickness, is going into a hyperbaric chamber. After that, people realized we can heal those diabetic wounds or non-healing wounds. So, and that's been going on again for 50 or 60 years now.
Okay.
But the part for neurological patients, neurological indications, including stroke, that's pretty new. That is something that Professor Fradi and myself are leading the investigations and the studies on it and the protocols to do it, like I said, from 2008. Before 2008, no data was there other than anecdotes. So we took it to the next level of, okay, let's actually study this. Let's show what's going on. Do we get benefit from it? And what's the mechanism behind it? So we're talking about anywhere between 13 to 14 years old field. I would consider it rather new. And I think the potential is just getting started.
Yeah, 13 to 14 years ago. I mean, it's not that, it's very new. I mean, I had my first brain hemorrhage in 2012, and in 2012, podcasts really weren't a thing yet. You know, the internet was just getting started. There was a lot of lack of information out there, and there was a lack of us, the stroke survivors, being able to access that kind of information. So it's fairly new, I would imagine, but that's good that it's been happening since 2008. I imagine you've got some good data by now. You've got some proven therapies by now, and you've helped a lot of people. Tell me a little bit about the actual work that you are doing and the things that you've discovered.
So, like I said, the first study that we've done, we tested neurological function, motor function of patients with different neurological deficits. And we showed that we can actually improve motor function as well as speech function. You know, people who have their areas of speech affected by bleeding or ischemia from the stroke can lose their ability to talk. So we showed that we can regain a lot of those capabilities back. The next studies focused on cognitive function. I don't know if people know this, but apparently up to 50%, 50, of stroke survivors suffer from cognitive deficits, whether it's attention, memory, or processing speed is slowed down significantly. Because, you know, people think about stroke, okay, it's just his hand or it's just his leg, but a lot of times it's all about cognition, that he's not the same person anymore. He cannot go back to work because his brain doesn't work the same it was. So definitely we focused on cognitive function, and we showed we are able to improve all the cognitive domains, like I said, memory, attention, executive function, processing speed, coordination. We can regain a lot of the capabilities that were lost. Afterwards, we wanted to understand, does it matter what type of stroke you got? Obviously, there are different types. There's ischemic ones when you have closure or occlusion of an artery, and you have the hemorrhagic ones, like you mentioned you had, where the artery actually is ruptured. And also, you can have it in different areas of the brain. And you can have it in your dominant side or your non-dominant side. We know that most people are, their left hemisphere is dominant. So if you have a right stroke or a left stroke, does it matter to our results? So we spent a lot of time studying this, and we found for most of it, it does not matter. It does not matter where you had a stroke. And the reason for that is how we select patients. And I think that's the critical part that I want to convey here. A lot of people saying they're doing hyperbaric oxygen therapy, whether they're doing it at home or clinics, or the real thing is how you determine if a stroke survivor fits the treatment, if the treatment will actually benefit for it.
Mm-hmm.
So you have to do evaluations. So all of our patients go to specific evaluations that include cognitive assessments, physical assessments, and imaging. And in the imaging, we do two specific modalities. We do the MRI, that I'm sure a lot of people know about, which can tell us the anatomy of the brain, where was the stroke, what kind of damage happened there. But then on top of it, we do another assessment called a SPECT scan. SPECT scan measures the function of the brain, or the metabolism of the brain. So we measure on each area of the brain how much metabolism it works. Think about how much glucose it's eating right now to determine if this area is completely destroyed, or it's normal functioning, or it has very low function that we can restore. So we want to work on areas that have low function, but not completely destroyed. Those are the areas that we can bring back to life or bring back to function.
Mm-hmm.
So during our evaluations, we look at the brain and we look, do we have those areas? We call those brain wounds or brain penumbras. These areas, if we see them, then we know that, okay, we can improve those areas, but we need to know where are they located and how do they correlate with the patient's symptoms. If they're in areas that if we will regain function, will it help the clinical symptoms? So that's the evaluation that has to be done in order to determine if we're going to help the patient. If that's being done appropriately, and if we select the patients based on that, on the imaging compared to the symptoms, then it doesn't matter what type of stroke, hemorrhagic, ischemic, and what's the location of it, and dominant or non-dominant. All that matters that you selected it correlated to the symptoms, to those low metabolism areas. So again, take-home message, patient selection. If you're gonna do hyperbaric oxygen therapy, you have to do it in a place that's doing evaluation and determines if it's gonna help you or not. It's not like, oh, I'm stroke survivor, let's go in. Not that.
I understand. Okay, so not everyone is going to be a candidate for hyperbaric oxygen therapy. Okay.
Correct. A lot will, but some of the patients are not. Some of the patients are at the point that it's not going to work. And when you think about it, that's how medicine always works. You have a treatment, it works for a significant portion of the patient, but on some it won't. And you have to do this patient selection, because if you're going to treat everyone, it's never going to work. Think about acute stroke. When patients arrive to the hospital, either getting a TPA or an endovascular intervention, we do patient selection. Not everybody can have those procedures, depending on their time, on their imaging, on a lot of things, because we cannot do it for everyone. So patient selection for this medical intervention is critical.
Yeah, fair enough. Makes complete sense. And that's kind of one of the issues with getting your own tank, putting it in the house, and not having been evaluated by anybody for any reason. You might invest $20,000 in something that provides a certain number of risks at home anyway, but then also maybe completely ineffective.
Correct. Completely. It's a medical intervention. You have to do it with the professionals. I think people should really understand what they're doing. It's taking medicine into their own hands. They shouldn't do it like any other intervention. Like they wouldn't do an endovascular intervention on themselves because they think they just now have a stroke. It's the same thing. It's unsafe and it may be ineffective and it may be dangerous. So don't do it.
Fair enough. All right. So the disclaimers are out of the way. Everyone has been forewarned.
Perfect.
All right. So then with the particular study, you guys selected your group, and then what happened? How did you go through the process? And yeah, talk me through that.
Okay. So we're talking about the study or a flow of a regular patient right now?
Yeah. Yeah, you take me through the process. I don't really know. I'm just
Okay.
I want to learn. You take me through the process. I'm very happy for you to guide the conversation. Yeah, for sure.
Sure. So when we evaluate the patient, so patient comes in and it can be 2 months after a stroke or it can be 10 years after a stroke. I always tell a patient, we need to do evaluations. I cannot determine if it's going to help you or not based on looking at you. I can't. I need to do actual medical investigation. So the patient comes in, we see them, we evaluate them, we do a medical intake, we do physical examination, neurological examination, and then we start with a cognitive assessment. So they usually go and sit with a neuropsychologist. They sit in front of a computer and solve these, games, you can call them, but they're actual cognitive tests, testing their memory or their attention and all of the cognitive domains. It's all being done objectively on a computer. And then they meet up with a physical therapist that again tests everything, their range of motion and their growth strengths and their reflexes, everything that we do, and their gait, everything that's related to their injury and overall neurological status. Then the patient also goes to the imaging facility where they go and have their MRI. So an MRI very similar to a CT scan that a lot of the people here know about. Lie down in the scanner, makes a lot of noise for 40 minutes or less, maybe 20 minutes, get their brain scanned, and then they move to the SPECT scan, which is a very similar machine. Usually we inject some tracer into the veins, and then they're being scanned about 40 minutes afterwards. Patient goes home. We process the data for about 2-3 days. We want to make sure we have everything, all the evaluations. Each professional writes up their report and their summary because we want it to be multidisciplinary. So we meet up the physician, the neuropsychologist, the physical therapist, the dietitian, if we think there's value for diet here. And we talk about what each of us saw and the impression, what was it? And then the physician looks at the imaging. And what we do in the imaging, we have specific algorithms that take the MRI and put the SPECT on top of it. And then we calculate what we call the anatomical to functional matching. So we want to look at areas, like I explained earlier, that are not completely dead, not necrotic, but have low metabolism. Those are the areas that we want to take a look at. Can I share my screen? I'm not sure if it's visual or not.
The penumbras, right? You can show. So you're talking about the penumbras. Now, before you show anything, are we talking about, even in patients that are 10 years post-stroke, could there be penumbras active or able to be rehabilitated?
Yes, exactly.
Well, that's amazing.
That's the exact the exact thing that we discovered. There is something that's called a chronic penumbra. A lot of people know about the acute penumbra that we look in the first couple of hours of the stroke, but we've realized that there is a chronic penumbra years after the stroke.
Wow.
And that's exactly what we're
fabulous.
looking for in the SPECT.
Okay. Please do feel free to show us some of your images.
So I'm going to try and show a case.
If you've had a stroke and you're in recovery, you'll know what a scary and confusing time it can be. You're likely to have a lot of questions going through your mind. Like, how long will it take to recover? Will I actually recover? What things should I avoid in case I make matters worse? Doctors will explain things, but obviously you've never had a stroke before. You probably don't know what questions to ask. If this is you, you may be missing out on doing things that could help speed up your recovery. If you're finding yourself in that situation, stop worrying and head to recoveryafterstroke.com, where you can download a guide that will help you. It's called 7 Questions to Ask Your Doctor About Your Stroke. These 7 questions are the ones Bill wished he'd asked when he was recovering from a stroke. They'll not only help you better understand your condition, they'll help you take a more active role in your recovery. Head to the website now, recoveryafterstroke.com, and download the guide. It's free.
So this is a nice example of what we just talked about. So this is a 62 years old woman who suffered a stroke 14 months before coming to us. So a year and 2 months before that, she suffered a left side stroke, an ischemic stroke, meaning her MCA artery was occluded. And because it's on the left side and she's left side dominant, she suffered from right hemiparesis, meaning right weakness in the right side, and aphasia, meaning she was unable to speak. So we did the MRI and we did the SPECT scan, and what you see on the screen right now on the left side is the baseline SPECT. And again, this is on top of the MRI scan. This is co-registered. And what we're looking for here is the level of metabolism or level of function. So yellow is the average activity, red is high activity, green is low metabolism, low function. So what we found 2 specific areas that are low functioning. Here, what you see here, I don't know if you can see my mouse.
I can.
That's the motor cortex. That's
Wow.
the area of the motor cortex with low metabolism. And here, this is what we call the Broca area. This is the speech center. This is where we generate speech from.
Wow.
Both of these areas are green, meaning low metabolism. When we saw this, we said, okay, there is a logic to do the protocol. So we included her in the protocol that we're going to discuss in a minute. What is the protocol? And after 3 months of the protocol, this is her post scan. So we rescanned the same person afterwards with SPECT. And you see here the green areas, most of it became yellow, both in the motor cortex and both in the Broca. Here you see some leftover green, but most of it is yellow. And this correlated with significant improvement in her right hand and her right leg movement, and she regained speech. Again, it was not as perfect as she was before the injury, but she was able to talk. So this is 14 months afterwards. I don't know if everybody knows this, but basically when we give the prognosis or we predict what's going to happen for a stroke survivor, somewhere after the 3 to 6 months after the injury, the rehabilitation reaches a plateau. So whatever we regained in those 3-6 months stops. Here, we show that even 14 months afterwards, we still can regain rehabilitation.
Well,
this is kind of
that's
a very Yeah,
That's great news. I'll tell you why it's great news. Firstly, because people get to the plateau. Doctors don't do a good job of explaining what that plateau is and what it means. And then people leave hospital thinking that that's it, no more recovery for them. And that's a big issue when doctors send people home and they feel like there's no recovery. Then lots of things can get in the way to prove that there isn't going to be any more recovery. The patient becomes potentially one of the people that proves the doctor's right. And that can be sad if that's the case. But what I love here is that you've actually got imaging for the first, one of the first times, I imagine, where you're proving that beyond the plateau, there are penumbras that can be rehabilitated in the brain and therefore restore function. That is fantastic to hear. That is such an amazing thing.
exactly. And that's the key thing. That's the key, and that's how you select patients. You literally understood what we're talking about. We want to see those chronic penumbras. We prove that they're there, and if we find them, and we find them in most of our patients,
Wow.
we find them and they correlate with the symptoms, then we should do the hyperbaric oxygen therapy protocol. That's exactly it.
That is amazing. That's so heartwarming. That's so good to hear and see, to actually visually see that. Now, when you first discover this, do you know what you've discovered? Do people gather behind you and support you to take this to the next level? How does it get up to that next level? Because I imagine in 2008, when all this started, you guys would have been excited, but were you able to get the rest of the community excited?
We're trying. I gotta tell you, this is a working process. This is a working process, and I'm meeting with neurologists and neurosurgeons day in, day out. I need to give the same talk and show them everything again and again, because even though we publish, it's not out there as much as it should. So it's slowly getting there. We're doing our best, but still,
Good work.
needs to be out there.
Good work. So just before we go into the actual protocol, I'm wondering about what you're actually achieving here. So we hear about neuroplasticity, and a lot of stroke survivors, it's one of the first things they hear about when they go into a hospital after they've had a stroke, and when they go into rehab for the first time, you get the neuroplasticity speech. And I think that's an amazing speech, because, neuroplasticity can occur simply by imagining yourself walking. You can be creating new neural pathways to support the pathways that are no longer there, or pathways that have been lost, so that you can, when you go back to therapy, as you begin to walk, you're enhancing the neural pathways that you've just imagined in the past, and then you walk, even if you're in the stirrups, even if you're holding onto the bars, even if you're in your cane or whatever you're doing. And then what you're doing is creating new neural pathways to go around, I suppose, for lack of a better medical word from me, to go around the old ones which are no longer working, right? Now, in this case, are you reigniting old neurological pathways that were there? Are you bringing cells back to life? What are you actually doing to the brain when those penumbras are rehabilitated? How does it work?
Awesome. So there are 4 components that we have discovered that by doing our protocols that we're actually doing. So the first one, we're providing energy to reignite. I like that sentence you used. Reignite those areas that were not dead. So the necrotic areas, after several months, the areas that suffered from damage beyond repair, they're dead, and there are no cells there. There are no cells there. It's just water. So on those areas, on water, we cannot work. But those areas with the penumbras, those are cells that are alive, but are not transmitting electricity. So they have enough energy to survive, but they're not doing action potentials that actually transmit data. Those are the areas that we reignite with the high level of oxygen. That's number one. Number two, what we found, we have a specific protocol. And again, we're going to talk about exactly how we do it. But we're doing something called oxygen fluctuations, meaning that each time the patient goes in the session, we're doing several minutes with oxygen, several minutes without oxygen. With oxygen, without oxygen. What it does, it's something we call oxygen fluctuations. So high level of oxygen, normal level of oxygen. High level of oxygen, normal level of oxygen. What it does, it tricks the brain. It tricks each cell in our brain to think that it's suffering from stroke again, that it's under stress, that it has low level of oxygen all of a sudden. The reason we're doing this is when the brain feels this, it triggers a specific molecule called HIF-1 alpha, or hypoxic-induced factor 1 alpha. That's the trigger for brain repair. And we have that in the first 3 months. That's why we finish up with the plateau, because the brain secretes that on its own in the first several months, but then it stops. We are able to force the brain to continue to secrete this molecule, this trigger of brain repair. Just by tricking this high level, normal level, we're tricking it to continue repairing itself. That's number two. And this is critical that we're doing it on a safe level, because the other way you could have had it if you, I guess, cause multiple strokes on yourself or choke yourself, but that's unsafe. By doing it high level to normal, we're never in the unsafe areas, and we're still triggering brain repair. That's number two. Number three effect that we are able to do is we have shown we are recruiting stem cells, neural stem cells. We're actually bringing neural stem cells that can build new nerves in the brain areas that were injured. They're not building it anywhere. They're just building it where the injury happened.
I like that. I'm going to interrupt there. You said something really important. You said they're not building it anywhere. So you hear a lot about stem cell therapy, and usually they're infusions or injections, and they're not targeted. They're just going to any particular place. And it seems like they hope for the best. And that was one of the things that I kind of struggled with when I heard about stem cell therapy, is that how do you know where the stem cells are going to go? How do you get them to go where you want them to go? So what you're doing here is by tricking the brain into thinking that it's hypoxic because it's had that increased boost of oxygen, and then you've taken it down to normal levels. It's going, oh my gosh, we got problems right here. We need to create neural stem cells right here, right now, in that spot.
Exactly the thing. You know, I couldn't have phrased it better. I think a lot of people are injecting stem cells in the spine, in their veins. I was even part of a study that, you know, we did it intracranial, so people injected stem cells in the brain itself. It doesn't work. And, you know, every decade we see another study that people try to do it and it doesn't work. And the reason it doesn't work, because these are external stem cells that have no reason to, oh, I'm injected here, okay, I'm going to build something. They don't have the trigger that I mentioned, and they don't have the infrastructure to stay there and build it. So they're just being injected there, floating around, and die. That's what happened to the stem cells that are being injected in so many clinics, so many areas. So, and it's a shame. I mean, it had good logic, but then again, it doesn't have good logic. And every decade, people think that they solved it, So far, all these external injections do not work. What we're doing is we're using our own endogenous, meaning our own body's stem cells flowing to where they're needed. And the fourth component is also the critical part that people are forgetting, the infrastructure. Stem cells will survive if they're being supplied with oxygen and blood. They need something to survive. They're not just, it's not like a petri dish that you put them on and they're surviving. They need something to hold on. So the fourth component of our protocol is inducing blood vessels. So we are building new blood vessels that are being formed in those areas. And again, in the areas that need it. It's not, we don't get new blood vessels in our hands. It's just in those areas. We see that, so the stem cells can actually be supported to build new nerve cells. So in medically or scientifically, it's called angiogenesis, the generation of new blood vessels, and neurogenesis, the creation or generation of new nerve cells. So those are the four effects that we're actually doing.
New blood vessels, is that a fairly recent discovery? Is that something that's been recently understood? Because I didn't realize that we could increase the number of blood vessels in our brain.
So we know about new blood vessels from the wounds. So we knew that hyperbaric medicine or hyperbaric oxygen therapy induces new blood vessels in those diabetic wounds. And I think that the biggest concept, and again, I guess I'm going to share a very slide here that's kind of critical to understand. This is a nice slide from the Weizmann Institute in Israel that was recently published. And what it shows on the left side is how a wound in our leg or in our hand is healing. And on the right side is a wound in our brain, which is a stroke. And, when I grew up, when I got my medical education, people have told me you cannot repair the brain. Nothing can. But we know today, in this decade, that it's not true. We can repair the brain. And amazingly, it's pretty similar. It's exactly the same concept. So this comparison is beautiful. So the cells' names are different, but it's exactly the same things happening here. We need new blood vessels. We need the inflammatory cells. We need new nerve cells coming in. All these processes are occurring exactly the same in the wound in our hand and in the wound in our brain. Okay. And when we understand this, we can supply those four components that I mentioned. So since we knew that in the wound in the leg, we are actually getting new blood vessels, we just tested it out in our brains, in our stroke, and we showed that we're also doing the same thing in our stroke area. We are creating new blood vessels.
I love it. Absolutely love it. So what we're doing is the good thing about seeing this on a wound on the leg is that we get to see the wound heal. We physically get to see it heal and close over, but we can't see inside the brain under normal circumstances. So that would be invisible. And I imagine when you guys first discovered this in 2008, the people came to you, they said, oh, we feel better in the head. Our cognition is different. Our stroke symptoms have eased or changed or become better. And that makes sense that you would go, well, okay, that doesn't mean anything to us because we saw the wound heal on the leg or on the arm, but we didn't visually see anything inside the head. So let's go through the process of proving that by doing a study. I love the way the whole process has worked and the way you guys think and the way that it's got like that. Now, what I also love about it is that visual, that slide, it makes a real big difference to me because when I'm doing stroke recovery and I get to see and I get to go through the process of hearing that I've reached the plateau, And then by chance, I learn about the penumbra. And now by chance, I've learned about the penumbras that persist, that are there beyond the plateau, that can still be rehabilitated. And then I get to see the proof, the physical proof of a wound healing on somebody's arm, which confirms that there are blood vessels occurring or regenerating in that particular wound. And then I get to see the same thing in the brain. You've got me convinced. I've understood the whole path, the whole process to get me to the point where I completely, totally understand how we can restore function in the brain in a spot that's been previously damaged. That's fabulous.
Perfect. I love that. I reach to the crowd and people understand these concepts, because it's not easy to understand. And you know, I have physicians and neurologists that it takes time for them to process it, but that's what we're trying, and that's what we're trying to convey here. And this is great news, like you said.
Yeah, it is great news. I think neurologists have a different way of thinking about things. I think very simplistically, right? So I don't need a lot to be convinced. And sometimes that's the challenge, is with stroke survivors, they don't need a lot to be convinced. They say, they hear something about hyperbaric oxygen therapy, they go buy a tank, they put it in their house, because the guy who sold it to them convinced them very easily or very well that that's what they needed. So they went and got it, right? Whereas I might be that way inclined, but this just makes me feel a lot better about the whole thing, and you're not selling me anything, and that's even better. So
Yeah.
so that's awesome work. I just love the work that you guys are doing. So is that the entire protocol? That's part of the protocol, right?
So I guess let's go back to our journey. So we started with our assessments, right? We did the cognitive, we did the physical, we did the imaging. We correlated symptoms with the imaging. We determined that the patient is eligible and will benefit from this. And then it goes through the program. What does the program include? So the program is 3 months, 60 sessions, 5 days a week, 2 hours a day, inside the chamber. And inside the chamber, each time they need to do our protocol, the same protocol that we use in the randomized controlled trial. I don't know about different protocols. I know about this one. This one was able to induce those 4 components. So we do this 60 times, 5 days a week, 2 hours a day, 3 months. And then, and usually on top of that, it's really determined case by case if we're going to add cognitive training or physical training on top of the chamber to maximize efficacy. In the trials, we did not use them. We did not use any physical therapy, any cognitive training, because we just wanted to show the hyperbaric oxygen therapy effect. But obviously, when a patient comes in outside of a clinical study, I want to give him the maximal effect. So I give him the chamber, and then I consider, do I want to combine it with physical therapy and cognitive training, and maybe a specific diet if I think it's going to be beneficial. Do this 3 months, and at the end of the 3 months, we repeat everything. So we repeat cognitive function, we repeat physical function assessment, and we repeat the SPECT scan. There's no need to repeat the MRI scans because we know about anatomy. We want to see about metabolism. So we repeat the SPECT scan like we saw about the lady we saw earlier. We repeat it, and we want to see if we were able to heal those brain wounds, those areas of chronic penumbras. Exactly that.
Wow. So a 62-year-old person is not restricted by age with regards to being able to generate their own stem cells?
Nope. We have actually done an aging study. We've done an aging study on people over 60, 70, and 80 years old, and we have shown that we're recruiting the number of stem cells just as much as we do on younger people.
Wow. That's good news too.
Yeah.
Because it's
exactly.
because
So
it's
there's no
often,
restriction in it.
yeah, because it's often suggested that people who are older are probably candidates for stem cell injection therapy or something along those lines, because of the fact that they are older and because of the fact that they are less likely to be able to generate um, growth hormone and other factors.
They're unable to in their normal physiology. As we get older, we don't have the trigger for repair. But if you're doing the protocol, you're forcing their body and their brain to induce those triggers, just like you do in earlier. So it's true that normal physiology makes an aging brain to do less repair. But if you're forcing it to induce the trigger, it will repair itself.
Okay. So your patient has to commit to a fair routine, a fair regimen of treatment, 5 days a week, 2 hours a day. Are those 2 hours in the chamber at the same time, or are they different times? Or
Usually the same time. We can accommodate if a patient needs to move it here and there, but usually it's same day, every day, 5 days a week.
2 hours solid in the chamber.
Correct.
Okay. Where does your work take place? Which part of the world?
So we started in Israel. That's where we did all the research. And then we started deploying clinics. So we have a clinic in Dubai, in Asia, and a clinic in the United States in Central Florida. Those are the first two clinics, and we're expanding next year for more clinics. We'll have one in New York City, and more to come in, because the goal is to touch the lives of everyone we can. We haven't discussed this, but as you know, stroke is the real pandemic. You know, people have learned the word pandemic in the past 3 years, but stroke is the real one. You know, it happens every minute, anywhere in the world, and there are so many stroke survivors that people don't even understand how many. So we want to reach out as much as possible, anywhere we can, and to provide them with the high quality protocol that we know that can help them.
Yeah. 1 in 4 people, I think the World Health Organization says, that will experience a stroke in their lifetime. It's dramatic, and a lot of those people, majority of those people, end up with some kind of a disability, and it's a big challenge. Is the particular protocol that you're able to facilitate people for, is it expensive? How do people pay for that? Is it reliant on their insurance? How do you go about bringing people on board?
I think that's the most painful part, at least for me. Right now, it's not covered by any insurance, so it's all out of pocket for the patient. It remains a bit expensive, I would say, for a lot of patients. I think that's, well, I don't think, I know this is my life goal, to make it approved, and that's why I do my studies. We are planning to do more and more research in order to get it approved. You know, in order to get a medication or any procedure approved by insurance, it takes a lot of time, a lot of years to get approved. We are doing this. We are in the process, but it will take many more years until we get that approval and signature here. The insurance is going to cover it, but that's what we're doing. That's what I'm doing. But for the time being, it's not covered and it's out of pocket for the patients.
Yeah. The people who are deploying the clinics in other countries, are they deploying them on your behalf? Are they other colleagues that are involved in the research? How does another clinic get set up? Of course, we don't need to know the whole process, but like, how does somebody get a new location gets selected and then a new clinic established?
So I'm part of the team of the company that doing those clinics. I'm the chief researcher and the head of the medical operations. So when we set up a new clinic, it's being built from ground, and we select our physician. I train them personally on the protocols and how it's done. And I usually spend time with the physicians in the clinic for several months in order to make sure we get high quality protocols and we select the right patients, we do the right treatments, because I'm as strict as possible on the quality that we want to deliver. So I personally oversee everything.
Now, I know I'm a stroke survivor, so like, it's my favorite topic to discuss, helping stroke survivors. So I love that work. But when I'm on the website at avivclinics.com, and I'll have the links for the website in the show notes, I'm noticing there's a whole bunch of other things that that oxygen therapy has helped people with, including PTSD, including people that are 82 years old, helping them to run marathons, including a whole bunch of other things. But the PTSD one really struck me. So again, is that something that was discovered by accident through these types of protocols and that has expanded into other areas of research? How did these things come about?
Awesome question. So my other passion as a neurosurgeon, except stroke, is traumatic brain injury, which is a very, I guess, political or discussed matter. You can get traumatic brain injury from sports like the NFL, rugby, or you can get it in the military from different accidents, different explosions, different events, or even a regular motor vehicle accident. So I treated a lot of traumatic brain injury patients. And we saw a lot of them are suffering from different disabilities after that treatment, whether it's a mild concussion or whether it's a severe injury. And again, during my residency, after the stroke study was completed, when we understood about chronic penumbras, we said we need to understand what's going on with traumatic brain injury. And we basically found the same thing. If you had a traumatic brain injury several years back, we want to see if we find penumbras. We want to see if we find penumbras in your brain. And if so, do they correlate with those symptoms? And if so, we can treat them. So we have done this, again, several randomized clinical trials, both in adults and in pediatrics. And out of that, just to go back to your question, some of TBI patients suffer from PTSD. And then we got the reports from several of our patients that their PTSD is changing. And I got to tell you, in the first couple of sessions, it can actually deteriorate. We found out that in the first 2 or 3 weeks, people are re-experiencing things, and we had to help them go through those several weeks. And afterwards, they go back into sessions and they come out differently. And when we realized we can actually affect PTSD, we started our randomized controlled trials for PTSD. One of them is still running right now in Israel. And we're seeing some nice results. We're going to publish them. We did the first study on it. Now we're reconfirming the evidence we've got. So very exciting. And it all comes down to understanding what's going on in the brain. Doing patient selection based on what we see on brain imaging and the correlation to symptoms. If you don't have it, it's not going to do anything. You have to actually see the brain and select your patient based on that, regardless of the pathology.
Dr. Hadani, this is a really amazing interview. Thank you so much. I really appreciate it. The information that you shared, I think, offers hope more than anything to the people who are listening and watching. If you're listening, you definitely need to go to the show notes so you can see the slides that we were speaking about. And if you're on YouTube, hopefully you've actually seen the slides that we're talking about, because I think they really, a picture paints 1,000 words as far as I'm concerned. So they're really important. I'll plaster them everywhere and make sure that you guys get to see them. I just wish you guys every success in the work that you're doing. I think it is going to be unbelievably successful. I hope that you guys have clinics all over the world, and I'm looking forward to the first clinic opening in Australia. I might go and visit it myself.
Thank you so much. Thank you. I'm really hoping to get as much as possible done and get it all proved and help as many stroke survivors, because really this is a life goal of mine, and we hope to succeed and actually affect people's life. Do good is our motto.
Dr. Hadani, thank you for being on the podcast.
Thank you so much.
Thank you for joining us on today's episode. I hope you got a lot out of this particular interview. I certainly did. The hope that the work that Dr. Hadani is doing and that it offers stroke survivors is really, truly amazing and groundbreaking. They're talking about things that I've never heard before, that is very seldom spoken about, these long-term spots in the brain that are still kind of low in energy and need some assistance to get back to working in some way, shape, or form, and then hopefully restoring some potentially lost function to stroke survivors, even after many, many years beyond stroke. So the fact that the imaging has got to the point where it is enabling people to find these new places, these new penumbras that can be rehabilitated is truly amazing. I was really excited to hear the information that Dr. Hadani shared. Now, if you would like to learn more about my guests, including links to their social media and other pages, to download a full transcript of the entire interview, please go to recoveryafterstroke.com/episodes. If you would like to try the course 5 Foods to Avoid After Stroke, go to recoveryafterstroke.com/courses. If you would like to support this podcast, the best way to do it is to leave a 5-star review. This is a really important thing that I would ask anyone listening who has a moment and can do. Please do leave the show a review, because it's going to make it easier for other stroke survivors like you who needed this type of information, find it easier, and that's going to make it better on the path to recovery for them. For those who have already left a review, thank you so much. I really appreciate it. It does make a huge difference to how we go through this recovery process. If you leave a few words on iTunes and Spotify, they're the best places. Also on YouTube, you can leave a comment below. Ask me a question. I'll respond. I will answer your questions. Give the show a thumbs up, subscribe. Any interaction with any of these podcast episodes just makes a massive difference to the way the search engines make it so that other people can find the show. Now, if you're a stroke survivor with a story to share, come and join me on the show. The interviews are not scripted. You do not have to plan for them. All you need to do is be a stroke survivor. Care somebody who is a stroke survivor, and be one of the amazing people like Dr. Hadani, who do work that improves the lives of stroke survivors. It doesn't matter whether you're a doctor or an allied health professional. Anyone at all who's in that space is welcome to join us on the show. Go to recoveryafterstroke.com/contact, fill out the contact form. As soon as I receive it, I will respond with more details on how you can choose a time that works for us both to meet over Zoom. Thank you for being here and listening. I really appreciate you. See you on the next episode.
Importantly, we present many podcasts designed to give you an insight and understanding into the experiences of other individuals. Opinions and treatment protocols discussed during any podcast are the individual's own experience, and we do not necessarily share the same opinion, nor do we recommend any treatment protocol discussed. All content on this website and any linked blog, podcast, or video material controlled this website or content is created and produced for informational purposes only and is largely based on the personal experience of Bill Gasiamis. The content is intended to complement your medical treatment and support healing. It is not intended to be a substitute for professional medical advice and should not be relied on as health advice. The information is general and may not be suitable for your personal injuries, circumstances, or health objectives. Do not use our content as a standalone resource to diagnose, treat, cure, or prevent any disease for therapeutic purposes or as a substitute for the advice of a health professional. Never delay seeking advice or disregard the advice of a medical professional, your doctor, or your rehabilitation program based on our content. If you have any questions or concerns about your health or medical condition, please seek guidance from a doctor or other medical professional. If you are experiencing a health emergency or think you might be, call 000 if in Australia, or your local emergency number immediately for emergency assistance, or go to the nearest hospital emergency department. Medical information changes constantly. While we aim to provide current, quality information in our content, we do not provide any guarantees and assume no legal liability or responsibility for the accuracy, currency, or completeness of the content. If you choose to rely on any information within our content, you do so solely at your own risk. We are careful with links we provide. However, third-party links from our website are followed at your own risk, and we are not responsible for any information you find there.